little bit. So we're going to start now. I want to begin by welcoming everyone to Neuroscience Grand Rounds. Today we have a guest speaker, which we're all very excited to have here. Dr. Jonathan Scoville comes to us from Chicago, from Northwestern University and Lurie Children's Hospital. Dr. Scoville started his training in his career at BYU, where he studied biochemistry, and then went on to the University of Cincinnati for medical school, where we crossed paths. And he was on track to become a cardiovascular surgeon, and he just needed to meet me and deflected his career trajectory into neuroendovascular surgery and pediatric neurosurgery. And so very happy outcome for him. He finished his medical school at University of Cincinnati and then went on to do his residency training in neurosurgery at the University of Utah, where he did a enfolded neuroendovascular surgery fellowship, and then did his pediatric neurosurgery training, a one-year fellowship at Lurie Children's Hospital, and then took his first faculty position at Northwestern University and Lurie Children's Hospital, where he is now an assistant professor. And he is going to speak to us today about a topic that's near and dear to me, and I'm excited to hear his talk. It's about pediatric cerebral venous sinus thrombosis. And without further ado, let's welcome Dr. Jonathan Scoville. Thank you.
Good morning, everyone. Thank you for having me. Is there a way to advance slides? Keyboard. Oh, here we go. Thank you. Thanks for having me here. It's been great to come out to Phoenix and meet everybody. And back when we were discussing topics about what to talk about, Todd pitched doing pediatric cerebral venous sinus thrombosis and thrombectomy. I think there's been a lot of, it's been a lot of interest, especially recently, in this area. And I think there's a lot that we can learn and still do. And so I'm excited to talk to you about this. I don't have any disclosures, although I'm always looking for some. I always like to start my talks with an analogy, so I'm going to try and tie in something I've been learning about recently, which is Ulysses S. Grant and his life and history of the Civil War. I'm going to try and tie that into pediatric cerebral venous sinus thrombosis and also just like cerebral sinus thrombosis in general. But so this is Ulysses S. Grant, and from a historical perspective, he never looked like a man destined for greatness. He graduated in the middle of his West Point class, and even though he served bravely in Mexico during the Mexican-American War, and his position as a quartermaster would serve him well later, just a few years later, he had resigned from the Army under a cloud of failure, underlined by accusations of drunkenness, accusations and an addiction that would follow him and haunt him most of his life. He drifted through one unsuccessful job, from one unsuccessful job to another, farming, real estate. He's even selling firewood at one point on the streets of St. Louis, just to keep food on the table for him and his family. He was at one point so destitute, he pawned his family heirloom, his pocket watch, so that he could pay for food. By 1960, he was back in Illinois, working in his father's tannery shop in Galena, Illinois, on the Mississippi River, and he was working as a clerk. Then the Civil War broke out, and then the Civil War broke out, and he volunteered for the Illinois Regiment. And he quickly, with his West Point training, he quickly rose up the chain of command and became a general. That's when his character started to show. He was calm under fire, unshaken by setbacks, and most importantly, he moved and he acted. The early part of the Civil War was the North was plagued by ineffectual generals who were afraid to move. They had overwhelmingly larger forces, but they didn't want to risk anything. And so they saw defeat after defeat and setback after setback until Grant started to actually fight in the Western Theater. And where others saw risk, he saw opportunity, and it was that decisiveness born out of years of his hardship that carried him through the war. And nowhere was it more important than his Vicksburg campaign, which was a masterpiece of audacity, speed, and relentless pressure that broke the Western theater of the Civil War and turned the tide, some say, for the entire thing. So Vicksburg is a small town in Mississippi, but it's right on the Mississippi in this bend in the Mississippi River. And I'll show you, it kind of looks like this. And Vicksburg sits on this big bluff. And back in the 1860s, the South had entrenched themselves there and built a fortress with large cannons and guns that could fire at any passing ships along the Mississippi. And it really blocked the North's ability to get to the coast or the ocean and use the Mississippi as a means of transit. So by 1963, Grant was given the task of taking Vicksburg, and Lincoln called it the key. And he was right. If Vicksburg fell, the Confederacy that held Mississippi would fall as well. And it would be cut in two. You cut the South in two and basically split their armies. But it was nearly impregnable. And conventional wisdom said it couldn't be taken, but Grant disagreed. He tried many ways to get there through back channels, and then eventually that didn't work, and he ultimately had to just do, in the middle of the night, he took his boats down the river just past it, and miraculously didn't lose a single soldier during the convoy. And then just south of Vicksburg here, he was able to go into Mississippi, and then he marched on Jackson. And in 17 days, he fought and won 5 battles: Port Gibson, Raymond, Jackson, which is the capital of Mississippi, Champion Hill, and Big Black River, beating Confederate reinforcements before they could unite. Then moving swiftly, he swung around and encircled Vicksburg, and then he entrenched it for 47 days, and then they broke the siege and finally took the city. Grant didn't give the enemy time to regroup, which was really what the key was to taking Vicksburg. He didn't let them dig in. He moved quickly, and he kept striking until the fortress collapsed. So what does that have to do with cerebral sinus thrombosis? Well, that is exactly the posture we need when we face cerebral venous sinus thrombosis. Cerebral venous sinus thrombosis is our Vicksburg. The clot entrenches itself in the venous sinuses, threatening the lifelines of the brain. If we hesitate, it grows stronger. If we wait, the damage spreads. When we act quickly, we can, and if we are decisive, with anticoagulation, with escalation when needed, with relentless support, we can turn the tide. Like Grant Vicksburg, success depends on boldness, speed, and persistence. When we talk about cerebral venous sinus thrombosis, I like to say that, neurosurgery in general is a treatment of the rare, unless, you're talking about degenerative spine in adults. And pediatric neurosurgery is the rare of the rare. And vascular pediatric neurosurgery is the rare of the rare of the rare. So, we're talking about 0.5 to 1% of all strokes are cerebral venous sinus thromboses. And that's the same for pediatric ischemic arterial stroke. It's like 1% of all strokes. It affects about 12.3 per million people per year as the incidence, and about it accounts for about 5% of ICH in the young. So very low numbers in general. The risk factors, prior medical conditions like thrombophlebitis, inflammatory bowel disease, transient situations like pregnancy, dehydration, which is probably very common here in Arizona, especially at higher altitudes, infection, medications, oral contraceptives, which is very linked and has a great risk or huge risk profile for this, and substance abuse, and then unpredictable events like head trauma. When we look at the spread of who it affects, it's a young person's disease, typically striking in the 2nd and 3rd decades of life. Can happen later on as well, but that's the most common. When we look at where it occurs, the majority of them occur in the superior sagittal sinus. And it can lead, when that occurs, it can lead to headache, increased intracranial pressure, and papilledema. Motor deficit, sometimes with seizures, can occur. Scalp edema, dilated scalp veins can be seen on examination. For the lateral sinus, symptoms related to underlying condition like a middle ear infection, may be noted. They can have constitutional symptoms like fever and ear drainage. Pain in the ear, mastoid region, and headaches are typical. Approximately 16% of patients with cerebral venous thrombosis will have thrombosis of the deep cerebral veins, like the internal cerebral vein, vein of Galen, and these can be devastating. They can have thalamic and basal ganglial infarction. Those patients with those will persist with rapid neurologic deterioration. Cortical vein thrombosis is uncommon, but can lead to specific clinical outcomes like if the Lobé thrombosis, you could, on the left side, you can have speech or aphasia, motor deficits, and hemorrhage. Presenting symptoms for these patients, 90% of them will have headache, which kind of clouds the picture and it leads to a delay in diagnosis overall. 40% of patients can have seizures. We talked about motor weakness, sensory changes, 6 nerve palsy because of the elevated intracranial pressure, which is also more common in children. Altered mental status, papilledema, and blurry vision. I'm a lumper, not a splitter, so I like to look at these in 2 major categories. One is those that are related to increased intracranial pressure attributable to impaired venous drainage, and those are related to focal brain injury from venous ischemia or infarction or hemorrhage. Several important clinical features distinguish cerebral venous thrombosis from other mechanisms of cerebrovascular disease. First, focal or generalized seizures are frequent, occurring in 40% of patients, like we talked about. Second, an important clinical correlate to the anatomy of cerebral venous drainage is the bilateral brain involvement is not infrequent. This is particularly notable in cases that involve the deep venous drainage system, where bilateral thalamic involvement may occur, causing alterations in level of consciousness without focal neurologic findings. Bilateral motor signs can occur, including paraparesis and by hemispheric injury. Finally, patients with cerebral venous thrombosis often present in a slowly progressive symptoms. Delays in diagnosis are common and significant. And one of the biggest cohort studies, they found that symptom onset was acute, usually less than 48 hours in 30% of patients, subacute in 48 hours to 30 days in 56% of patients, and chronic in 7% of patients. So most patients are actually coming after multiple days of symptoms before they come to the hospital. The median delay from symptom onset to hospital admission was 4 days, and from symptom onset to diagnosis was 7. Elevated opening pressure is frequent finding and is present in about 80% of patients, but lumbar puncture is not usually necessary, especially with imaging diagnosis. Patients with IIH or with suspected IIH should have venous imaging just to rule out suspected thrombosis as well. This is what it looks like on imaging. Only about 30% of CT heads, non-contrast CT heads, will show an abnormality, which really shows the need to have venous imaging, either MR venogram or CT venogram, to confirm the diagnosis. Usually, diagnostic angiogram is not necessary because, especially today with CT venograms and MR venograms, are so good and sensitive. All right, so going back a little bit to Civil War trivia. So this is Rear Admiral David Dixon Porter. And he was a naval officer that worked with Grant during his time in the Western Theater. And he commanded the ships on the Mississippi, Tennessee rivers during the battles of Tennessee and Mississippi. He had ironclads like this, which were famous at the time. They would put steel plates on these ships and ride them low in the Mississippi River so that if they took shellings that they would not sink. They were basically floating fortresses. Grant formed a partnership with Admiral Porter in which they worked very well together to utilize the naval forces and also the ground forces to do kind of a 1-2 punch. Utilizing this 2-pronged attack, the naval and ground forces was very effective. For them, we can use systemic anticoagulation and mechanical thrombectomy. It's kind of like a 1-2 punch for treatment of cerebral venous sinus thrombosis. So let's talk about treatment. So the first line treatment is anticoagulation with unfractionated low-weight heparin, or followed by oral agents for 3 to 12 months. And this has been demonstrated I think that initially when people were looking at cerebral venous sinus thrombosis and hemorrhages, they were worried about propagation of the hemorrhage. And there have been multiple trials that have shown that actually initiation of early systemic anticoagulation is not only safe, it's necessary to ensure good outcomes in these patients. So there have been 2 randomized controlled trials, 2 boxes up top, one of which had small numbers, and the other one which was stopped early because of the efficacy, which showed that with anticoagulation, the outcomes were much better. So the first trial compared anticoagulation versus placebo. Primary outcome was cerebral venous thrombosis severity scale at 3 months, which evaluated headache, focal signs, seizures, and level of consciousness. The secondary outcome was ICH. The trial was stopped early after 20 patients of the planned 60 were enrolled because there was a benefit to treatment. Among 10 patients in the heparin group, 8 recovered completely, 2 had mild deficits at 3 months. Among 10 patients in the placebo group, 1 recovered completely, 6 had minor deficits, 3 died by 3 months. So 2 patients treated with placebo and none treated with heparin developed ICH. So the other trial of 59 patients compared anticoagulation with placebo for 3 weeks, and then everybody got oral anticoagulation for 3 months. 13% in the anticoagulation group had poor outcome compared with 21% in the placebo group. No intracranial hemorrhages in either group occurred after initiation of anticoagulation. There was a meta-analysis done of these 2 groups, which showed that the risk assessment in favor of anticoagulation, the relative risk of death of 0.33. The largest study by far is this international study of cerebral venous thrombosis, which is this box down here, which included 624 patients at 89 centers in 21 countries. Nearly all patients were treated with anticoagulation initially, and mortality was 8.3% over 16 months. 79% of people had complete recovery, MRS 0 to 1. 10% had mild to moderate disability, 2 to 3, and 2.2% remained severely disabled, 4 to 5. Hemorrhage on presentation is associated with worse outcomes, but anticoagulation does not necessarily lead to worsening hemorrhage or worsening outcomes if it gets bigger on anticoagulation. Those are the conclusions of that study. So, the first line treatment is systemic anticoagulation as soon as possible. And I think we've learned from this and these other studies that anticoagulation actually does not impact, or not only does not impact the growth of the ICH, but actually is very necessary to ensuring good outcomes for these patients. The other treatment modality is mechanical thrombectomy. It's currently offered as salvage therapy if patients decline neurologically despite therapeutic anticoagulation or have progressive thrombosis on therapeutic anticoagulation. Those options include microcatheter microwire maceration. It's taking a microcatheter into the superior sagittal sinus or transverse sinus, moving your microwire and microcatheter up and down to try and break up the clot. And that has been shown to work in some patients in case reports. Aspiration thrombectomy, which has now become kind of the or is now emerging as more of the standard in ischemic stroke, with bigger catheters, larger bore catheters, and better suction devices. Stent retriever thrombectomy, placing the stent retriever up and pulling clot out as well. And then clot-directed thrombolysis, you put a catheter and then you do direct TPA injection on the clot itself. There's also a device called now I can't remember it. I have a slide on it next, but so we'll get back to that. There's a device that utilizes the Venturi effect to push fluid and TPA around and suck it back in, which is pretty neat. And that's been pioneered in the peripheral artery space for thrombectomies and is now being used now in cerebral venous thrombosis as well. And there's also balloon-assisted thrombectomy and then combinations of everything. So this is the angiojet. That's the name. Let's see if this will play. This, but this is the angiojet, which is a a new device, or it's been around for a few years, but they keep updating it. It uses the hydrodynamic thrombolytic action occurring at the tip of the catheter via the Venturi effect from high velocity saline jets. The thrombus is disrupted and directed down the second lumen of the device. Perforations on the venous sinus, or perforation on the venous sinus wall may occur, but it's very rare, and at a rate that it's unknown, but reported in small existing series. It may be avoided by removal of the angiojet after partial recanalization and thrombosis and follow up with additional microcatheter thrombolysis. It's a neat concept. It's been used for peripheral venous sinus, or not venous thrombosis, thrombectomy in peripheral artery disease and deep vein thrombosis. This is, so when we talk about thrombectomy, we always want to, when we do any intervention, we always want to make sure what we're doing is safe and effective. This is the only trial to date, only randomized controlled trial for endovascular treatment of cerebral venous thrombosis. It's the 2-act trial. The hypothesis was that mechanical thrombectomy plus anticoagulation would improve outcomes in patients that were more likely to have a poor outcome. So they included patients with certain risk stratifications that would put them into the higher risks category, and they would do earlier thrombectomy on those patients. They could do within 24 hours. Unfortunately, it was stopped due to futility after 55 patients enrolled because there was no benefit. And we'll kind of talk about why I think that is, but this is what it looked like. 67 patients were ultimately randomized, 33 to the endovascular, and 33 to standard medical care. The patients on endovascular treatment also got standard medical care. And then they followed them for 12 months. One of the major issues with this trial was that 67 patients were enrolled, but 420 patients were 67 patients were enrolled, 420 patients were seen with cerebral venous thrombosis during that time at these hospitals, and 26, so almost the same number of patients that got enrolled and got endovascular treatment were treated outside the trial with endovascular treatment. So tells me there's a little bit of lack of equipoise, and it's going to mess with your data. 91% got mechanical thrombectomy, and then 9% just got thrombolysis, which is another problem with this trial. But if you look at the primary endpoint, which was MRS 0 to 1 at 12 months, and we think back to that international study of cerebral venous sinus thrombosis, where it said that 80% of people had 0 to 1% or MRS 0 to 1 at 16 months. They got about that same score, 70% of people, which is what you'd expect. So the trial was a little bit set up for failure, knowing that the international study of cerebral venous thrombosis showed on anticoagulation patients have about 70 to 80% chance of having a good outcome. They anticipated they'd only have a 60% chance of having a good outcome. So that's what they powered it for. But needless to say, everything looked about the same at their interim check. And then, the safety events were about the same as well. Obviously, there were no difference in hemorrhagic complications or new symptomatic ICHs in the groups, although they weren't powered to find that difference. So major limitations of this study is that the high number of patients treated outside the trial during the trial period, 50% of potentially included patients. There's no standard method for intervention. So this reminds me of the IMS-3. And maybe, I don't know if everyone remembers IMS-3. It was the big stroke trial, one of the initial ones that came out in like 2012 before the 2015 acute ischemic stroke trials came out and showing effectiveness. And they just were able to use whatever they wanted. They treated everything everywhere using whatever they wanted. It was a pragmatic study. Problem with pragmatic studies when you're figuring out what to do is that everybody does things a little bit differently and you get differing results. So there's no standardized method of intervention. They did not assess length of stay or ICU days, which is also like a good outcome measure to follow. And their primary outcome was MRS 0 to 1. Now that's probably based on the good results that came out of the trials of the international study of cerebral venous thrombosis before, but relaxing that MRS outcome would allow you to see functionality potentially and the differences in that. So these are the major limitations with that trial, and we'll talk about it again in a little bit. But I just wanted to talk a minute about decompressive hemicraniectomy. So in a lot of other diseases in pediatric and adult neurosurgery, decompressive hemicraniectomy is actually associated with poorer outcomes. But in a review of patients that underwent decompressive hemicrania, they achieved, or a recent review of 13 patients that got it for cerebral venous thrombosis with elevated ICPs, 84% had a favorable outcome. So this disease process, if you can get the patient through the acute period, and they tend to do well. And I say that caveat with those that have deep venous thrombosis and thalamic infarcts, but those don't usually need decompressive hemicraniectomy or craniotomy. So decompressive craniotomy may be needed as a life-saving measure if large venous infarction leads to a significant increase in intracranial pressure. And the patients can have a meaningful recovery still. So, and again, a lot of them are younger as well. So when you take everything together, this 1-2 punch, grant, Porter, naval, armed forces, you get this kind of proposed algorithm. So you have a clinical suspicion of cerebral venous thrombosis, get imaging, it's confirmed, you initiate anticoagulation with either heparin, with heparin or something similar. If they have neurologic improvement or stable, you continue the oral anticoagulation for 12 months. And then and you can treat the underlying reason for their thrombosis. And if they have neurologic deterioration or coma despite medical treatment or worsening, hemorrhage or mass effect, then you can consider endovascular treatment. That's kind of where we are right now with our algorithm. I'm going to shift gears a little bit, and now we've talked mostly about adults, which is how we tend to do things in vascular neurosurgery, is because the kids are so rare, we don't have the numbers, so we do a lot of the studies in adults, and then we start to transition to children. So that was a lot of adult data. Now we'll talk about pediatric specific. So pediatric cerebral venous sinus thrombosis has a very low incidence, as you'd expect. It's 0.67 per 100,000. And most of them, about 43%, are in neonates. And that is because the mechanical forces exerted on the infant's head during birth can result in molding of the skull bones on the suture lines and mechanical distortion of or damage to the underlying dural venous sinuses. And neonates also have an increased thrombotic tendency due to transplacental transfer of circulating material antiphospholipids to the fetus, which can persist into the newborn period. And neonates have reduced levels of circulating anticoagulant proteins, including protein S and C and antithrombin, and higher hematocrits relative to adults, which leads to hemoconcentration. And they usually don't eat very well for the first few days, so they're dehydrated. So they have all these things that are going against them and could lead to venous sinus thrombosis. And it's associated with higher frequency and adverse outcomes in neonates in older children, and children with neurologic deficits are observed in 28 to 83% of neonates long-term. So whereas in the adults, they tend to have very positive outcomes with treatment with anticoagulation, neonates unfortunately are the most common pediatric cerebral venous sinus thrombosis, and they have the worst outcomes. But we should still anticoagulate. And there have been some studies, there's limited, but there have been some studies that have looked specifically at neonates to make sure that this was safe, right? We always want to make sure that it's safe and that we're not leading to increased intracranial hemorrhages or decreased outcomes. There is a Netherlands cohort of 10 neonates, 7 received a low molecular weight heparin therapy, and they had no increased or new hemorrhages during treatment. Toronto did at sick kids, they did a a longer term study and cohort where they looked at specifically preterm neonates, and they had 26 preterm infants. 73 of them were symptomatic with either seizures or decreased neurologic exam. 69% of them got anticoagulation. 50% had neurodeficits on last follow-up, and no patient had worsening hemorrhage after initiating anticoagulation. So again, not everybody got anticoagulation, and that's probably because of practice patterns and desire, and that there's no really strong evidence to do it. But nobody had increased hemorrhages. So the takeaway is that if you have an infant neonate with cerebral venous sinus thrombosis, you should anticoagulate them. When we look at that, when we look at the IPSS, which is the International Pediatric Stroke Study, which has been going on since 2003, and it's a prospective cohort enrolling all pediatric patients that have had a stroke. These are the patients that have had cerebral venous strokes due to cerebral venous sinus thrombosis. There's a total of 170 patients aged 1 month to 19 years that were enrolled, and they represent 65% of patients in the IPS cohort with CVST, and about 14% of the total patients in the whole cohort that had ischemic stroke or venous sinus thrombosis of all ages. And when you look at how well the older children do, they do just as well as the adults, it looks like. So, when you look at how well they do, they don't do as well as the adults. About 84% of them go home, but 43% of them had neurologic deficit at discharge. So it's unknown. This study didn't show us, long-term outcomes, but they did not do as well as the adults in terms of their outcomes from cerebral venous sinus thrombosis. When we look at the risk factors for having an abnormal neurologic status at discharge, you can see age. Obviously, the younger the patient, the more likely they were to have a poor outcome, and then decreased consciousness, seizures at presentation, the extent of thrombosis was related, and hemorrhage also was related to worsening status. So now looking at pediatric thrombectomy in these patients. So there's been no randomized controlled trial for thrombectomy in pediatric patients. And when you talk to, the luminaries in the field like Dr. Abruzzo or Dr. Orbach or these other people, we're not doing very many. It's obviously less common than ischemic stroke, and even an ischemic stroke, we're not doing very many of those. So this was a paper that was published between 5 centers in which they treated 5 centers, they treated 7 patients. They were all treated differently. Again, there's no standardization. 3 patients had direct TPA as well as thrombectomy. But the outcomes were also very good. So for the 5 patients that were treated, 1 patient was severely neurologically disabled and bedbound due to extensive venous infarction long-term, but everyone else was either an MRS 0 or 1. And the authors of this paper suggested that endovascular intervention be considered in children with severe cerebral venous sinus thrombosis and rapid neurologic decline who have failed frontline therapy and have access to experienced endovascular practitioners. They argue that the predominantly positive outcomes of patients in these series and lack of hemorrhagic complication argues for its consideration once all other measures have failed, and not to wait for significant neurologic deterioration. So again, we want to do this earlier if possible. We think that earlier is better, but we want to allow those patients that are going to get better on anticoagulation to get better as well. And we don't know yet really where that line is. But modern endovascular treatment using large bore aspiration, stent retrievers in combination with local thrombolysis may enhance its efficacy, and standard thrombectomy treatments appear to be safe and effective in children. In the appropriate situations, intervention should proceed without delay to maximize the chance of recovery and prevent neurologic injury. So again, I think The endovascular devices are improving all the time. And we'll kind of talk about that also, but one of the biggest issues, I think, with venous sinus thrombosis and the materials we have right now is that our materials are meant for the arteries that we're using. So when you think about the sagittal sinus, it's about 1 centimeter wide, and it's a V shape. And when you put a 8 French catheter, which is huge catheter for the arteries, into the venous into the sagittal sinus, it's only 2.4 millimeters diameter. So it's dwarfed by the size of the sinus. And it's circular or oval shaped. And so it's not the correct shape, it's not the correct size for these issues. So we don't have good materials. We need better materials. But this is another case series that came out of the UK, where most patients received site-directed IATPA. They had 9 patients. They assessed the outcomes after endovascular therapy, and these patients that failed to show clinical improvement. And in these patients, there were 2 18-month-olds, so younger children, which the other series did not have. It was like 12 to 17. 7 of the 9 patients were comatose at the onset of endovascular treatment, but favorable outcome was achieved in 8 of the 9 patients. And there are 15 other cases of endovascular cerebral venous sinus thrombosis that I could find in the pediatric population in the literature. I'm not going to go over all of them with you, but this included a case series of 6 patients that were treated using intrasinus urokinase, 5 using intrasinus TPA, 1 using the penumbra aspiration device, but in 2010, so not like very recent, and 1 using the angiojet device. In one series of endovascular treatment of 6 patients for continuous TPA alone, it was administered for 48 hours with the maximum dose of 60 milligrams. In their series of the 6 patients, 4 survived without functional deficit. However, 5 of the 6 patients demonstrated evidence of hemorrhage, including subdural and small parenchymal hematomas, not requiring intervention. But this is one of the few trials that showed an increased bleeding risk with continuous IA-TPA or IV TPA in the sinus or at site TPA over a long period of time. But they gave them huge doses. So, okay. So I just wanted to show a couple cases to kind of demonstrate. So I'll show an adult case and a pediatric case, kind of give a sense of what we're dealing with in the real world here. So this guy came in last Monday, actually. So a 53-year-old male, history of factor V Leiden, deficiency recurrent lower extremity DVTs. He was on Lovenox, but he had an L5S1 paracentral disc herniation that just had to come out. So they stopped it for surgery. Post-op day 3, he presented with right-sided hemiparesis, hemianesthesia upon awakening at 8 a.m. and was found to have this right-sided parietal hemorrhage. And you can see on the CTV, he's got this, the sigma sign here of this this clot in this superior sagittal sinus. So this is his fourth thrombectomy angiogram of the sinuses, and this is the after. So you can see that the frontal part of the sinus fills, but the back part is absent. And then after thrombectomy, and you can still see our catheters here, but just look, this is the catheter. This is a big catheter. It's an 8 French catheter. Just look how dwarfed it is by sinus. And this is just kind of an AP showing you the aspiration catheter going up into the sinus all the way to the top. You can see it there, you can see it there. And then we were able to recanalize superior sagittal sinus. So he came in, when we saw him in the ED, he was intubated and sedated from the outside hospital. But yesterday he was awake, talking. Yes, still has some weakness from the hemorrhage, but is able to move his left side. So we'll see how he does overall. And we've continued him on anticoagulation, and his hemorrhage is not increased. This is a case of a 16-year-old female. She presented with 10 days of worsening headaches. This is kind of the classic presentation, this delayed presentation. Blurry vision, progressive disorientation, and slight right upper extremity weakness. Imaging identified a left parietal hemorrhage and left transverse sinus thrombosis. You can kind of see this clot sign on the CT here, and then on the MRI as well. Initially started on anticoagulation. However, on day 6 of anticoagulation, she worsened and developed right-sided hemiplegia without worsening of her hemorrhage. So she also was taken back for a thrombectomy, and you can see in this panel here, again, the anterior, the frontal and anterior part of the central sinus is a fill. And then, after thrombectomy, we were able to get everything to fill again. At 6 months, 1 year and 2-year clinical follow-up, she demonstrated complete resolution of her motor and speech problems. She had some significant short-term memory dysfunction still and difficulties in reading and writing. And her MRV at 1 year demonstrated complete patency. So again, just to go back to this is the SINS guidelines that were just published for cerebral venous sinus thrombosis. Obviously, if it's suspected, history, risk factors, symptoms, get imaging, CT venogram or MR venogram, and DSA if unable to do either of those, which is unlikely, but those are frontline CTVs, very good, especially now. MRVs can be done quickly with some certain protocols, and in kids that might be better. And then you start treatment. Endovascular treatment indications are clinical deterioration despite anticoagulation, contradictions to anticoagulation, coma. So if they are already in a coma, you might consider it a deep cerebral venous sinus thrombosis because of the poor outcomes and the risk of having a poor outcome despite treatment and ICH. It's a little more aggressive than what was previously published. Hemicraniectomy for large lesions with herniation. You can do intracranial pressure monitoring, but it's not necessary for the exam. And then obviously diagnosis, find out why it's going on. So this was just, this is an editorial that came out in the Journal of Neurointerventional Surgery just this month. It was written by, all the thought leaders in the field. And basically it said that we should be doing more of it, we should do another trial. This is what they said. They called for another trial of cerebral venous mechanical thrombectomy and cerebral venous sinus thrombosis. And they brought up the points that I've already mentioned. We need a standardized method to do it so that we can really show efficacy. We need to have better inclusion-exclusion criteria. So instead of including everybody, including those patients that would do poorly, maybe we should just look at patients that would do well anyway, because that's what we do for stroke. We included smaller strokes, anterior circulation, because with the IMS3, it didn't work. And then we need to develop devices that are specific for the venous sinuses. And, we should also look at outcomes such as length of stay, days in the ICU, time of revascularization, cost, things like this that will matter as much as outcome data. So the victory at Vicksburg was more than just a battlefield triumph. It was the culmination of Grant's rise from obscurity to prominence. For the first time, the Union controlled the entire Mississippi River, effectively cutting the Confederacy in half and crippling its ability to move men and supplies. Lincoln himself declared, "The father of waters again goes unvexed to the sea," quote unquote. For Grant, it was a validation of his boldness, proof that his instinct to act decisively, to take risks when others hesitated, could reshape the course of the war. Vicksburg also transformed Grant's career. Until then, he had just been another Union general, often doubted because of his rough background and unconventional style. After Vicksburg, he became the Union's indispensable commander, the man Lincoln would later place in charge of all Union armies. It was a campaign that propelled him to greater heights, ultimately leading to the end of the Civil War. Just as Vicksburg marked the turning point of the Civil War in medicine, decisive treatment of cerebral venous sinus thrombosis can mark the turning point between devastating clinical decline and full recovery. So what are our next steps? further randomized controlled or prospective case control cohorts with more stringent inclusion and exclusion criteria, avoiding those patients that are likely to have poor outcomes despite any treatment, identify a specific treatment protocol, one device, one strategy, to limit provider error with devices designed for venous sinuses, and translate these findings to the pediatric population. Any questions? Thank you very much. Yes.
How long do you recommend, or is there evidence to show how long you should hold the heparin after a training or after ice fire, these sorts of?
Yeah, so as little as possible. So, I mean, that's what everybody says. In my practice, we will start heparin immediately after the surgical intervention.
Have you seen?
Well, I started slowly, but I have not seen any major issues yet. And I mean, it's rare, so. And patients needing hemicraniectomy for it is also even more rare. But I've seen people hold it for 2 days, 48 hours, is generally like that. Well, I'll usually start it as soon as they're stabilized.
I have a few questions.
Yeah.
And that was terrific, by the way. Think you could tell because the one time I picked up my phone was to take a picture of one of your slides. And that's a miracle in this day and age. So what about, if someone comes in with a large clot and they're herniating or taking out the clot, I know in some centers they do that, in some centers they just do the hemicraniectomy.
Yeah.
What are your thoughts on that in this particular scenario where you have to initiate the patient?
Yeah, I think that I guess if they're herniating and they have signs of clinical, brain herniation, I think you have to take the pressure off. Right? That's the number one thing. So either doing it by hemicraniectomy or it's probably the fastest and most decisive way to take care of that. But then, treating the actual issue with either thrombectomy because you want to wait to start the anticoagulation is so you can reestablish some blood flow. It's probably a good idea. Nobody really talks about that or protocols for that. And then starting anticoagulation once you feel comfortable. But again, thrombectomy can be used in those settings where they can't have anticoagulation up front because they need surgery or something else. So that's what I would advocate for, I think, is, keep the kids safe, get the bone off if you need to, and then do a thrombectomy so you can reestablish some flow to treat the underlying problem, and then get them on the anticoagulation once you feel ready.
Two other real quick ones. Is there one modality, CT, venography versus MR, that you think is particularly better in kids? I mean, we know one's faster.
Yeah.
Is there anything that's looked at that which is more
accurate? The CT venogram is the only one that has a sensitivity specificity related to it because that's the only one that's been studied at large. MR venogram doesn't have any studies that actually looked at venous sinus thrombosis, so we don't have sensitivity specificity for it. And that being said, I think today most places have adequate imaging that either one will work. I will put that with the caveat that you really need to have a high statistician to look for it, especially with MR. It can be a little more tricky and that can be missed, especially as subtle signs of it. So CT venogram has a higher specificity for it.
Then, final quick question. I don't know if you're where you are, you get called about these, but probably once a month or so, people come in with rip-roaring mastoiditis. They'll find that they have, a transverse sigmoid that's out on that side.
Yeah.
But they're asymptomatic from it. What is your practice in terms of treat versus not treating, and how do you follow this?
Yeah, if they're asymptomatic, I usually just put them on aspirin, actually. And then once they feel safe about it, and then you see them in 3 months, it's usually gone. Just hydrate, aspirin.
This came up recently.
Yeah.
Patient of mine was tumor, and then they got a routine tumor scan, which then showed that they had a transverse sinus clot. And I was told by the pediatric hematology team that it is their standard of care to fully intubate
Yeah, yeah, and that's probably true. And I mean, abundance of caution. And if the kid has no other risk factors for bleeding, it's probably the best way to treat it. But you know, if that patient came to me personally, I'd probably, it's just one-sided, it's not the dominant side. And they have no symptoms, I'd probably just put them on aspirin hydration and follow. But anticoagulation is probably the standard of care. So, but nobody's really looked at it in like a very a definitive way, honestly, especially those specific problems. That's why I love pediatric neurosurgery. Is there's just, you know, every day is a new problem no one's ever seen before or heard of. And you get to make it up as you go along. Any other questions?
Yeah, just Jonathan, really enjoyed your talk. This is a great topic. It's sort of one of the last frontiers of our specialty because we've beaten everything else. Cured cancer, cured aneurysms, cured stroke. I mean, this is like one of the last things that we haven't fixed yet. And it's still controversial. I just a few comments and observations. I'm so excited about this topic. It's something we can treat very often. And I feel like we should be treating it more often. The inversion of outcome age relationship here is very interesting to me, and I think it has a lot to do with postnatal remodeling of the venous circulation in the brain, which is not, you know, usually the younger the patient, the better the outcomes, right? And that's not true in this disease, right? The outcomes are worse in younger patients. And so we know that there's a lot of postnatal remodeling of the venous circulation in the brain. You know, you have cavernous capture that occurs after, you know, the first 3 months of life. And then beyond that, there's a lot of postnatal remodeling. I think it has to do with the balance between ventricular-femoral and ventricular-pedal venous drainage and the shift that occurs with postnatal remodeling. But I thought that was very interesting. I don't know if anyone else.
Yeah, I was hoping that nobody would ask me about that because I don't know the reason and I couldn't find, you know, I mean, that is, I mean, it's heartbreaking and it's interesting. It's heartbreaking the fact that the neonates are the ones that do the worst out of everybody who gets cerebral venous sinus thrombosis. Because the younger the patient, the worse outcomes.
Because they don't have cavernous capture. Yeah. And I think that's, you know, the cavernous sinuses annex the venous drainage of the superficial middle cerebral vein. And that doesn't, we're not born with that pathway, right? So our superficial middle cerebral veins are forced to drain to the posterior confluence through the superior septal sinus until that annexation occurs by the cavernous sinus. And then once that occurs, and this is true in the vein of Galen malformations, that if it becomes, if the disease becomes symptomatic before that annexation takes place, then they're in big trouble because all the venous drainage is directed to the posterior confluence where the vein of Galen is unloading all of its pressure. So the cerebral venous drainage is severely impaired. But if it becomes symptomatic after cavernous capture of the superficial middle cerebral veins, then all the cerebral venous drainage is directed anteriorly towards the anterior confluence of the cavernous sinus. But the vein of Galen can have the posterior confluence, the brain doesn't care. Right, so that is sort of the wonder if that is at play here. Yeah. Also, one of the outcomes that nobody pays attention to, which we see here, I've seen recently, is patients who become symptomatic with idiopathic intracranial hypertension, sometimes very early. And so it's not a late manifestation of this disease, so they're neurologically intact, but they develop papilledema and all the complications of idiopathic intracranial hypertension, and that's not even an outcome that we look at. So I wonder how this balance would shift in terms of the medical therapy versus interventional therapy. Would interventional therapy win in that comparison? We started looking at that as an outcome.
Yeah, great thoughts.
Looks like there's a comment in the chat.
Oh yeah, let's see.
Let's make this reading data. Just click on the chat.
Jeff Miller. Jeff is our chair guy. Perfect. Thanks, Jeff. Thanks for the comment. I want to close with a question. And so John, so, John, that's fantastic talk. At the very beginning of your talk, you talked about being a pediatric cerebral vascular neurosurgeon is treating the rarest of the rare. And when you're treating the rarest of the rare, good clinical data, strong trial-based data is nearly impossible, right? So you even showed the failed clinical trial of intervention for cerebral venous sinus thrombosis. And I imagine part of the problem is you now have a low incidence disease, okay? You have a rapidly changing landscape. Things that you're doing every year were not things that you're doing the year before. And so even designing a clinical trial, a meaningful clinical trial, for those of us that participate in clinical trials, when you design a clinical trial, you have to predict exactly how things are going to go in 5, because it takes about 4 to 6 years to recruit, to retain, to do all the things, right? And so what happens is you do these trials, and 6 years later, you're not even doing things anymore the way you were when you designed the damn clinical trial, right? And so my question to you is, where's the future here? How do we guide, in an evidence-based fashion, how do we guide therapy in these low incidence diseases? Like in your mind, like how do you see this going? Is it going to be small clinical series? Is it going to be consortia? Is it going to be maybe a prospective registry like we have in the HCRN? How would you design? What would you do?
Well, yeah, I'm a big fan of prospective registries. I mean, I think especially for these rare diseases, you just capture people and then you can ask questions. The biggest problem with interventions is that, especially pragmatic, like we talked about, is that, and you mentioned as well, if you treat somebody with a different device at a different time, it's not really compatible. But I think, you always go back to what makes sense. And it makes sense to get the clot out of the veins. And we know that anticoagulation doesn't alone, especially in the close follow-up period, doesn't get it all out. And so thrombectomy makes sense to help some of these patients. And there's probably patients that it works for, and there's probably patients it doesn't. We may never know exactly, but I think, we have to prove to ourselves that it works. And what, is disappointing with the 2 ACT is that it showed this outcome that didn't really resonate, and then it makes everybody a little bit afraid to do it. And so then we stop doing it and we become, less aggressive, and then the pendulum swings back and we get more aggressive. And so I think just defining guidelines that are more, that make more sense of when to do it and how to do it, and then tracking those outcomes for those patients. So, yes, clinical deterioration, but can we find those patients that we think are going to have clinical deterioration before they have it? I think that's the big question. And I think doing a large cohort of those patients, which deteriorated when, why, and what were the risk factors, I think you could find that. And then you determine guidelines that make sense for everybody.
I actually agree with you 100%. I think the greatest analogy, not a Civil War analogy, though I do love your Civil War analogies, is the DECRA trials, all the early sort of hemicraniectomy trials, in which really all you showed was that you were preserving life, but the Rankin scores were worse.
Yeah.
And so I think it was the same idea where everyone felt intuitively like it makes sense to take the bone off when someone is dying, right, from intracranial pressure. I think this is a very valid thought that you have.
I do also say, I want to be a scientist. I want to put my own biases in the forefront. And if it really doesn't work, and then I think initially at some point you have to cede to better medical therapies. And but as long as we're not hurting people, which it doesn't look like we are with these endovascular therapies, I think we can continue to try and make things better for the patients that don't have a good outcome.
All right. Well, thank you.
Thank you very much.